Hi, and welcome to this video about anxiety disorders. Anxiety can take on many forms. It can range from being frightening for the patient and their loved ones to being debilitating. It has physical manifestations as well as emotional and psychological. Let's look at some anxiety disorders and their symptoms and treatment. Panic disorder is a type of anxiety with a sudden onset of overwhelming fear when there is no imminent danger. Panic disorder carries physical symptoms such as rapid heart rate, chest and stomach pain, difficulty breathing, weakness, dizziness, sweating, feeling hot or cold, or having tingly or numb hands. You can imagine how frightening the symptoms alone can be. It has been described as an overwhelming feeling of losing control. It can strike the patient unaware at any given time. The symptoms a patient experiences are often called a panic attack. Panic disorder is more common in women and typically starts in younger adults. Treatment consists of psychotherapy, such as talk therapy, behavior modification, and antidepressants. The most popular types of antidepressants are called selective serotonin reuptake inhibitors, or SSRIs. Examples of SSRIs include fluoxetine, citalopram, sertraline, paroxetine, and escitalopram. Specific phobia is a strong, irrational reaction of fear to an object, place, or situation, which can disrupt activities of daily living. Specific phobias commonly focus on animals, germs, heights, thunder, driving, public transportation, flying, dental or medical procedures, and elevators. Although people with phobias realize that their fear is irrational, even thinking about it can often cause extreme anxiety. Specific phobia can occur in childhood, adolescence, or young adulthood. It can strain social relationships and affect self-esteem. Treating specific phobia is typically done with psychotherapy, talk therapy, and controlled exposure to the feared object or situation in the hopes of becoming desensitized to it. Antidepressant medications can be used in extreme cases. Generalized anxiety disorder is very common with more than 6 million cases in the U.S. each year. GAD is a persistent and excessive worry over a variety of things, including money, health, family, work, or other issues. It is common for people with GAD to anticipate disaster, which can make it difficult to get through the day. They don't know how to stop the worry cycle and will often try to control situations to aid in decreasing their anxiety. Cognitive behavioral therapy can help the patient with GAD by having the affected person express and discuss their feelings and learn about anxiety and its symptoms to aid in decreasing the escalation. It specifically looks at the physical symptoms of worry and the behaviors the patient exhibits due to the worry in the hopes of giving them tools to understand their behavior and develop coping strategies for it. Acceptance and mindfulness therapies look at behaviors and coping techniques such as yoga, meditation, and exercise. SSRIs are again beneficial in the treatment of this disorder. Because depression often accompanies GAD, the patient would benefit from treatment modalities for depression as well. Separation anxiety disorder is when an individual has anxiety in separating from a loved one, parent, or caregiver. This is often seen in children, but it also occurs in adults. Separation anxiety disorder is diagnosed when symptoms are excessive for the developmental age and cause significant distress in daily functioning. Symptoms may include recurrent or excessive distress about anticipating or being away from home or loved ones, constant excessive worry about losing a parent or other loved one to an illness or a disaster, constant worry that something bad will happen, such as being lost or kidnapped, that would cause separation from parents or other loved ones, refusing to be away from home because of fear of separation, not wanting to be home alone and without a parent or other loved one in the house, reluctance or refusing to sleep away from home without a parent or other loved one nearby, repeated nightmares about separation, frequent complaints of headaches, stomach aches, or other symptoms when separation from a parent or other loved one is anticipated. Separation anxiety disorder may be associated with panic disorder and panic attacks. Repeated episodes of sudden feelings of intense anxiety and fear or terror that reach a peak within minutes. Family environment and genetics may play a role, and stress has been known to be a factor. Treatment can range from psychotherapy to medication, as sometimes separation anxiety can lead to other anxiety disorders and depression. Selective mutism is a rare, complex childhood anxiety disorder where the child is unable to speak or interact in social settings, such as school, but is able to interact in settings where they feel comfortable. This goes way beyond being shy. The child is not choosing to do this, they cannot speak due to the anxiety. To be properly diagnosed, the symptoms must last longer than a month. A therapist will rule out physical causes such as speech and language pathologies and hearing loss and work with the child to model behaviors. They might have the child watch videos of them speaking with others or have them slowly introduced to the scenarios that are causing the mutism. Social anxiety disorder, also known as social phobia, has the defining characteristic of intense anxiety or fear of being judged, negatively evaluated, or rejected in a social or performance situation. At the thought of a social situation, these individuals suffer physical symptoms such as rapid heart rate, rapid breathing, and sweating, and will use avoidance as a coping mechanism. This disorder affects 15 million Americans and is the second most commonly diagnosed anxiety disorder. The extreme symptoms of social anxiety disorder can wreak havoc on activities of daily living, as the person may avoid jobs, schools, or social settings necessary to function in the world. There are treatments available, but only about 5% of people with the disorder seek treatment right away, while most suffer for years before seeking treatment. Treatments such as talk therapy, cognitive behavioral therapy, and if necessary, antidepressant medications help patients live with this disorder. Agoraphobia is the fear of social situations, similar to the previous social anxiety disorder, except agoraphobia is the panic attack that eventually can lead to the person not wanting to leave their home for fear they will have a panic attack when they do. Typical agoraphobia symptoms include fears of leaving home alone, crowds or waiting in line, enclosed spaces such as movie theaters, elevators, or small stores, open spaces such as parking lots, bridges, or malls, and using public transportation such as a bus, plane, or train. The panic attack associated with agoraphobia includes the following symptoms: rapid heart rate, trouble breathing or a feeling of choking, chest pain or pressure, lightheadedness or dizziness, feeling shaky, numb, or tingling, excessive sweating, sudden flushing or chills, upset stomach or diarrhea, feeling a loss of control, and fear of dying. Agoraphobia usually starts in late teen or early adult years before age 35 and is more common in women. Risk factors include another anxiety disorder, depression, and drug or alcohol abuse. Psychotherapy and antidepressants are the treatments for this disorder. To sum everything up, anxiety disorders can range from mild to severe, can be debilitating, and affect the person's activities of daily living. Thankfully, there are many treatments available, ranging from therapy to medications that are beneficial to patients with anxiety disorders.
One of the single most important concepts postulated by Sigmund Freud to explain the working of the human mind, the psyche, is his structural theory of human personality. Based on his observations, Freud proposed that the human psyche is extremely complex and is divided into three distinct but interrelated components, or agencies: the id, ego, and superego. Each of these separate but interacting agencies influence and are influenced in return by the other two elements to uniquely contribute to the development of a person's personality. As a manifestation of personality, behavior, a person's thoughts, actions, and reactions, is the product of the interactions of these three components. Let's take a look at the personality components of the id. The id is present at birth and is entirely unconscious. It is the earliest part of the personality to emerge and is the most primitive component. It works to satisfy basic urges, bodily needs, wants, and desires, including those of a sexual or aggressive nature, and it operates on the pleasure principle, seeking instant satisfaction. Now, let's look at the ego's personality components. The ego evolves from the id. It begins to emerge between the ages of 1 and 2 and operates on all three levels of consciousness, mostly in the conscious mind. It works to modulate the desires and impulses of the id in relation to the demands of the superego and reality. It also operates on the reality principle, striving to satisfy the demands and urges of the id while avoiding any negative consequences. The ego mediates and balances the opposing motives and drives of the id and superego with reality. The dynamic interaction of these three structures produces tension and conflict. How the ego achieves balance and resolves the conflict between the id and the superego defines how we behave in any given situation and cope with reality. According to Freud, a healthy personality results when the ego maintains this balance. With unresolved conflict or an imbalance among the id, superego, and reality, anxiety and/or psychological disorders occur. In an attempt to maintain control over the id, the ego employs defense mechanisms, which are automatic, unconscious mental strategies or coping styles utilized to reduce the anxiety and/or guilt associated with the situation or unresolved conflict and protect the person from their own dangerous impulses, unacceptable behavior, and unpleasant thoughts or feelings. It also helps mitigate the threat to the individual's self-esteem from the demands of the superego and reality. There are many different defense mechanisms used by the ego. Among the more common are denial, refusing to accept reality; rationalization, justifying behavior with a socially acceptable reason as opposed to the real reason; sublimation, converting unacceptable behavior to a more acceptable form; displacement, satisfying an impulse with a substitute; projection, attributing undesired impulses, thoughts, or feelings onto others; and repression, blocking a painful memory or unacceptable impulse. The use of defense mechanisms is both normal and healthy, and, according to Freud, necessary to effectively function in everyday life. However, the persistent use of or overuse of defense mechanisms may lead to dysfunctional behavior that can adversely affect the physical and/or mental health of the individual and become intolerable and harmful or unsafe to the people around him or her. Let's finish up by looking at the superego. This is the last agency to develop. Superego evolves from the id, emerging between 3 to 5 years of age, as family and societal ideals and values are internalized. It works to control or restrain the impulses, feelings, actions, and fantasies of the id. Partly working on a conscious level, the superego predominantly operates on the unconscious level. It operates on the morality principle, that is, it strives for perfection, regardless of reality. It serves as our moral compass. It is also comprised of 2 parts: the ego ideal, personal excellence, and the conscience, rules for behaviors. Now, let's go over some review questions. Number 1. Which of the following best describes what defense mechanisms are? A. Genetically wired responses to emotional threats from the superego. B. Unconscious mental strategies used by the ego to reduce anxiety produced by the interaction between the id and the superego. C. Abnormal coping mechanisms used by the ego to maintain control over the id. Or D. All of the above. If you chose B, you are correct. Number 2. According to Freud's structural theory, which key structures interact as the source of all behavior? A. Psyche. B. Ego. C. Id. D. Personality. Or E. Superego. If you chose B, C, and E, you are correct. Number 3. Which of the following is not true about the interaction of the ego with the id? A. It is commonly referred to as the moral compass because it maintains control over the id. B. When id behavior conflicts with reality and/or society norms, employs defense mechanisms. C. Modulates the desires and impulses of the id. Or D. Acts according to the reality principle, seeking to please the id's drive in realistic ways that will avoid negative consequences. If you chose A, you are correct.
Erik Erikson was a German psychoanalyst who developed a theory of psychological development that is still widely taught today, especially in nursing school, as part of the human growth and development. Erikson's theory relied on parents, society, and environmental factors to shape a person's development. Erikson's 8 stages of psychological development include trust versus mistrust, autonomy versus shame and doubt, initiative versus guilt, industry versus inferiority, identity versus role confusion, intimacy versus isolation, generativity versus stagnation, and ego integrity versus despair. The first stage, trust versus mistrust, is theorized to be from birth to approximately 18 months old. If a baby's needs are met by their caregivers at this stage, they will come out of this period with a sense of trust and a sense of hope as they grow into adulthood that everything will work out all right. On the other hand, if their needs are not met during this stage, it can cause the child as they grow into adulthood to not trust people and to potentially have anxiety and insecurities. Autonomy versus shame and doubt follows at approximately 18 months to 3 years of age. During this time, the child is recognizing separation from the primary caregivers and is able to start doing some things for themselves. They may start feeding and dressing themselves, as well as toileting themselves. This newfound autonomy helps build self-esteem. This stage requires patience on the part of the caregiver and is marked by a sense of personal control as a separate entity from the caregiver. The successful culmination of this stage is a sense of self-esteem. Initiative versus guilt, which happens from 3 to 5 years of age, is the stage where a child begins exploring their world more. This stage is marked by creativity and imagination. The child may pretend to be characters they see in the adult world. They like to try new things, such as learning to cooperate with others to achieve common goals. In this stage, children learn to perform more tasks and gain an understanding of social approval. The parent or caregiver can effectively help the child by allowing them to explore within limits. However, if the parents are over-controlling or very strict, this may cause the child to not want to explore and instead develop a sense of guilt. This can hinder creativity and cause a negative social effect. Success at this stage of development will lead to the virtue of purpose, which is demonstrated by how the children make decisions, come up with new ideas, as well as work and play with others. Industry versus inferiority typically happens from 6 years of age to 12 or 13. The child is learning many new skills and tasks and is starting to build a social network. They recognize what they can do and what their peers can do, and they make comparisons. Their parents or guardians are no longer their only source of belonging. If the child is able to navigate this stage successfully, they will gain a sense of competence. Identity versus role confusion is the stage of Erikson's psychological theory where the child is moving from childhood to adolescent years of 13 to 21, though some say the stage ends at the age of 18. This marks the stage of transitioning to adulthood. In this stage, the adolescent is learning who they are in the world and asking the big questions, like what is their purpose? While they are forming their identity, their body is going through physical changes. Soon, they start thinking about occupations in life, roles in life, their sexual role, and how they fit and don't fit into society. The adolescent can come out of this stage with what Erikson termed a sense of fidelity. In other words, the person can emerge with a sense of self-esteem and self-confidence when associating with their peers, having a developed knowledge of their values and beliefs. Intimacy versus isolation happens during young adulthood, 18 to 35 or 21 to 39. This is the stage marked by significant relationships, both with friends and with one special person. This is the stage where young adults may think about finding that one significant other and settling down. If navigated successfully, a person learns to give love physically and emotionally, and if severe rejection occurs or some other trauma associated with the primary relationship, this can cause a sense of isolation, with the person withdrawing from relationships and society. This stage is marked by personal fulfillment in giving and receiving love. Generativity versus stagnation, the 7th of Erikson's stages, happens from age 40 to 65. People in this stage want to be productive, leave a legacy, and contribute to society in a positive, changing way. Some major milestones of this stage may be children leaving home or changing career paths. Some people may struggle with a midlife crisis and search for meaning at this time of life. Left unsettled, this may cause stagnation and a disinterest in the people and world around them. But if successfully resolved, people develop the virtue of care, offering unconditional support to their children and other people in their life. Integrity versus despair is the last stage of life, taking place from around 55 or 65 until death. At this stage, the person is usually retired and reflecting on their past life and contributions. If they believe they were successful and navigated life well without regrets, they will achieve a sense of contentment and fulfillment or wisdom. If they have overwhelming regrets and wonder if it was all worth it, they may be dealing with despair. This person will tend to fear death, wondering what life was all about. To sum up Erikson's theory, successful completion of each stage results in a healthy personality and the acquisition of basic virtues, which the ego can use to resolve subsequent crises. Failure to successfully complete a stage can result in a reduced ability to complete further stages, and therefore a more unhealthy personality and sense of self. While vague in its application, as noted earlier, Erikson's theory is still widely used and taught today and is a framework for understanding a person's psychological development through their lifespan. Now, before we go, let's test your memory with a couple of review questions. Number 1. Which of the following is true when caring for a hospitalized infant and assisting with their development of trust, according to Erikson? A. When they cry, let them cry a little to see if they really have a need. B. When they cry, let them cry a while. It will help their psychological development. C. When they cry, let the doctor know how long and how often. D. When they cry, let mom or you respond as they are expressing a need. If you chose D, you are correct. When an infant cries, they have a need, and if we respond, this helps them develop trust that their need will be met. Number 2. Which of the following stages of psychological development represents a hospitalized adolescent benefiting from visits from their peers? A. Industry versus inferiority. B. Identity versus role confusion. C. Intimacy versus isolation. Or D. Generativity versus stagnation. If you chose B, you are correct. Adolescents relate more with their peers in this stage of development. Borderline personality disorder, also known as BPD or emotional dysregulation disorder, is marked by uncontrollable emotions and causes problems in daily life, especially with relationships. It is classified as a mental disorder that affects self-image and behavior. People with BPD can have episodes of intense anger, depression, and anxiety that can last anywhere from hours to days. The person is unable to regulate their emotions, and it is very difficult for them to return to a stable baseline. Struggling with self-behavior can result in the affected persons causing harm to themselves. 1.4% of the U.S. population experiences BPD, and 75% of those are women. Men are often misdiagnosed with having PTSD or depression. According to the Diagnostic and Statistical Manual, some key symptoms people may experience are frantic efforts to avoid real or imagined abandonment by friends and family, unstable personal relationships that alternate between idealization, I'm so in love, and devaluation, I hate her. This is also sometimes known as splitting. Distorted and unstable self-image, which affects moods, values, opinions, goals, and relationships. Impulsive behaviors that can have dangerous outcomes, such as excessive spending, unsafe sex, substance abuse, or reckless driving. Self-harming behavior, including suicidal threats or attempts. Periods of intense depressed mood, irritability, or anxiety lasting anywhere from a few hours to a few days. Chronic feelings of boredom or emptiness. Inappropriate, intense, or uncontrollable anger, often followed by shame and guilt. Dissociative feelings and stress-related paranoid thoughts. Severe cases of stress can also lead to brief psychotic episodes. BPD has been theorized to result from a variety of factors. It is believed that genetics or family history of BPD can increase the risk of developing BPD. Both chemical and structural changes in the areas of the brain that affect emotion and judgment have been associated with BPD patients. However, scientists aren't sure if the changes caused BPD or the changes came about due to the disorder. Environmental, social, and/or cultural factors where the person experienced a traumatic life event, such as abuse or neglect, have been theorized to contribute to BPD. There are no definitive diagnostic tests. BPD is best diagnosed after a thorough medical exam to rule out physiological diseases, past medical history interviews with the patient and possibly family and friends, and a thorough interview conducted by a mental health professional. Currently, psychotherapy and medications are the mainstays of treatment. Some of the psychotherapies used include dialectical behavior therapy, cognitive behavioral therapy, and psychodynamic psychotherapy. Dialectical behavior therapy, DBT, is a type of cognitive behavioral therapy. Its main goals are to teach people how to live in the moment, cope healthily with stress, regulate emotions, and improve relationships with others. Cognitive behavioral therapy, CBT, is a short-term, goal-oriented psychotherapy treatment that takes a hands-on, practical approach to problem-solving. Its goal is to change patterns of thinking or behavior that are behind people's difficulties, and in doing so, change the way they feel. Psychodynamic psychotherapy or psychoanalytic psychotherapy is a form of depth psychology, the primary focus of which is to reveal the unconscious content of a client's psyche in an effort to alleviate psychic tension. While there is no one medication specifically made to treat the core symptoms of BPD, several medications can be used off-label to treat various symptoms. For example, mood stabilizers and antidepressants help with mood swings. And for some, low-dose antipsychotic medication may help control symptoms, such as disorganized thinking. Short-term hospitalization may be necessary during times of extreme stress and/or impulsive or suicidal behavior to ensure safety. As always, patients should be screened for suicidal thoughts and ideations so as to prevent them from harming themselves. BPD can be difficult to diagnose and treat, and sadly, the person may also experience other mental health disorders along with BPD, such as anxiety disorders, bipolar disorders, eating disorders, depression, and substance abuse. Let's wrap this up with a review. The nurse caring for a patient with borderline personality disorder understands that treatments for the disorder may include A. Biochemical therapy and anti-epileptics, B. Physical therapy and neuroblockers, C. Cognitive behavioral therapy and mood stabilizers, D. Occupational therapy and antispasmodics. If you chose C, you are correct. Cognitive behavioral therapy and mood stabilizers are common treatment options for BPD.
Arnold Lazarus was a South African-born clinical psychologist and researcher who coined the term multimodal behavioral therapy. The idea behind the term is built on the premise that we are all basic biological beings who think, smell, touch, experience emotions, and relate to others. Lazarus lists the modalities in the acronym BASIC ID: behavior, affect or emotions, sensation, touch, smell, sight, hearing, taste, imagery, thinking in pictures, self-image, cognition, thinking in words, beliefs, attitudes, opinions, thinking styles, interpersonal, how we relate to others, and drugs and biology, medications, substances, diet, exercise, general health, sleep. We'll start with the first in the acronym, behavior. Behavior is defined as the way a person acts or conducts themselves, especially as they interact with other people. To assess behavior, the clinician may ask questions such as, what is this person doing or not doing that is affecting daily living and relationships? What behaviors do they need to stop or start? And are there any maladaptive behaviors or self-defeating actions? The patient may reveal these answers even as they are first meeting and speaking with the therapist, as their behaviors may be the source of discomfort or the reason they are seeking care. Drugs and biology must be assessed, and this area is sometimes assessed first. This assessment will take into account the patient's health beliefs as well as physical wellness. What do they believe about and do in regards to sleep, exercise, nutrition, weight, and alcohol and drug use? And are these habits considered healthy or not? Affect can be defined as the way in which a person expresses themselves, such as, she has a sunny affect, or his affect comes across as flat, depressed, or angry. The clinician may assess the patient by asking themselves, what emotions are predominant? What generates negative reactions? Or how does the person respond to questions and other interactions? The patient themselves may reveal during interactions what triggers certain behaviors or moods. Sensation can be defined as a physical feeling or perception resulting from something that happens to or comes into contact with the body. To assess sensation, see what sensations are felt or experienced when the patient is subjected to certain stimuli, noting if they have any sensory complaints. Examples might include certain sounds they cannot tolerate, like nails on a chalkboard or the creak of a slow closing door. To assess imagery, ask the patient about their self-image, or if there is any imagery that is constant or that they can't easily dismiss. This can include flashbacks and/or traumatic experiences. Cognition is the mental action or process of acquiring knowledge and understanding. This can be assessed by discussion of the patient's values, beliefs, and opinions, and noting if there are any that are problematic, dysfunctional, or irrational. Interpersonal functioning is how we interact and function with others. Who are the significant others in the patient's life? How do they interact with them? What does the patient want from relationships? What are their expectations, desires, and contributions? When a patient first presents with a complaint or a sign of distress, it will usually fall into one of these areas. This is a good starting point for clinicians to get to the root of the patient's problem, and then the other parts of the basic ID can be brought in as the patient and the clinician develop a rapport. Before we go, here's a quick review question to test your knowledge. If a patient is triggered by loud noises and begins to rock and cry, which part of the behavioral multimodal basic ID is being affected? A, affect, B, imagery, C, cognition, or D, sensation? If you chose D, sensation, you are correct.
Known as OCD, this mental health disorder is characterized by recurrent, uncontrollable thoughts that are irrational and arise out of different fears. Along with the uncontrollable thoughts are irrational behaviors that arise in response to the thoughts, which temporarily bring some comfort to the individual. The person may know intellectually that the thoughts and behaviors are irrational, but they are unable to control them. A hallmark defining feature is the obsession to perform the behaviors over and over, such as repeated hand washing. Most often, OCD begins in children, teens, and/or young adults, with men being thought to develop symptoms earlier than women. Most people are diagnosed by age 19, but diagnosis can range up to age 35. Some of the fears or mental images that cause a great deal of anxiety include fear of germs or contamination, unwanted, forbidden, or taboo thoughts involving sex, religion, or harm, aggressive thoughts towards others or self, and/or having things symmetrical or in a perfect order. Common compulsions include excessive cleaning and/or hand washing, ordering and arranging things in a particular precise way, repeatedly checking on things, such as repeatedly checking to see if the door is locked or that the oven is off, and/or compulsive counting. Not all rituals or habits are compulsions. Everyone double checks things from time to time, but a person with OCD generally can't control his or her thoughts or behaviors, even when those thoughts or behaviors are recognized as excessive. They spend at least 1 hour a day on these thoughts or behaviors. There's no pleasure when performing the behaviors or rituals, but the individual may feel brief relief from the anxiety the thoughts caused. They experience significant problems in their daily life due to these thoughts or behaviors. Some people with OCD have a bodily tic, which is a sudden movement they cannot control, such as eye blinking, shoulder shrugging, facial grimacing, or a head or shoulder jerking. Common vocal tics include repetitive throat clearing, sniffing, or grunting sounds. Symptoms can come and go or worsen over time. People with OCD may try to avoid situations that trigger the obsessions or compulsions they have. Patients may also try to self-medicate with drugs or alcohol in hopes of stopping the signs and symptoms of OCD. Risk factors for OCD fall into three main categories: genetics, environment, and brain structure and functioning. Genetics. If a first-degree relative, a parent, sibling, or child, has OCD, studies show a 25% higher risk of developing the disorder. Environment. Childhood trauma has been linked with OCD, and in some cases, children may develop OCD or OCD symptoms following a streptococcal infection. This is called pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, or PANDAS. Brain structure. In anatomy, structure always affects function, and in OCD, this may also be the case as frontal cortex changes in the brain have been shown on imaging in people with OCD. Treatment options include medication and psychotherapy. Medications include selective serotonin reuptake inhibitors, or SSRIs, and antipsychotic medications. SSRIs need to be given in higher doses in these patients and can often take up to 8 to 12 weeks to see benefits, but can give these patients relief from their symptoms. As with any SSRI, the patient should never stop this medication abruptly. Antipsychotic medications have also been known to help patients with OCD. With both of these classes of drugs, the patient should be monitored by their healthcare provider. These medications work well in addition to psychotherapy. Psychotherapy can be an effective treatment for adults and children with OCD. Research shows that certain types of psychotherapy, including cognitive behavior therapy, or CBT, and other related therapies, such as habit reversal training, can be as effective as medication for many individuals. Research also shows that a type of CBT called exposure and response prevention, EXRP, is effective in reducing compulsive behaviors in OCD, even in people who did not respond well to SSRI medication. EXRP involves spending time in the very situation that triggers compulsions, like touching dirty objects, but then being prevented from undertaking the usual resulting compulsions, such as hand washing. In 2018, the FDA approved transcranial magnetic stimulation, or TMS, as an adjunct in the treatment of OCD in adults. TMS is non-invasive and uses magnetic fields to stimulate nerve cells in the brain. Though OCD cannot be cured, it can be treated very effectively, and active research into treatment modalities continues. Now let's test your knowledge with a review question. Which of the following are risk factors for OCD? A, the patient used alcohol or drugs in the past. B, the patient engaged in risky behavior as a teen. C, the patient may have experienced childhood trauma. Or D, the patient may have low intelligence. If you chose C, you are correct. Childhood trauma is a likely risk factor for OCD.
Welcome to this video about the Bowen Family Systems Theory. Murray Bowen was a psychiatrist who began his career in psychiatry at the Menninger Foundation in Topeka, Kansas, and later worked at the National Institute of Mental Health and Georgetown University. Bowen was interested in the social, psychological, and physical aspects of psychiatry and came to believe that a person must be viewed in the context of family. In the 1960s, Bowen introduced the family systems theory, which focused less on the individual's psyche and more on the individual's relationships. Bowen considered the family as an emotional unit, with each member of the family affecting every other member, so that an individual is a reflection of and inseparable from the family. Family systems theory is based on 8 interconnected concepts, which are not sequential. These include relational triangles, scale of differentiation, the nuclear family emotional process, the family projection process, the multi-generational transmission process, sibling position, emotional cutoff, and the societal emotional process. Let's talk about these concepts one at a time. According to Bowen, the triangle is the basic unit of any emotional system, which is comprised of interlocking triangles, such as those found in nuclear and extended families. Triangles are inherently unstable because they are composed of a dyad and an outsider. A dyad, which consists of two people, is an unstable system because it tends to fall apart with stress. When one member of an apparently stable dyad is stressed or unhappy, the dyad becomes unstable, and the third person creates a different stable dyad, leaving one person in the original dyad, the outsider, and this process continues, triangle after triangle. In a calm state, the preferred position is in the dyad, so the outsider will try to join, but in a tension state, the outsider position is preferred because it is outside of the conflict. In any triangle, the uncomfortable one makes the move. The triangle is in constant motion as tensions arise and new interlocking triangles are formed. Bowen believed that the tensions created in the triangles are passed on from the top down as dyads form and break apart and new triangles are added to try to bring about equilibrium. So if an individual has problems such as mental health or behavioral issues, then the therapist needs to look not at the individual, but at those at the top of the triangles. The next concept is the scale of differentiation. Bowen stated that human functioning lies along a continuum from low self-differentiation, immature, to high, mature. This is one of the most important concepts in family systems theory. At the lower end of the scale, feelings and the intellect are merged, and people are unable to differentiate between feelings and thoughts. If they feel something, that is what they believe, so they are in an unfree state. Because they are ruled by their feelings, they often expend so much energy reacting to others and seeking love and attention that they can be miserable. They may be very dogmatic in their beliefs and may rebel. They have a poorly defined sense of self and are immature. Those higher on the scale, on the other hand, have an awareness of both their feelings and intellect, so they are in a free state. They can react with feelings, but still apply intellect because they are separate. These people have more individuality, a more clearly defined sense of self, and more maturity. People tend to marry or partner with someone who is about at the same level on the scale, so they have approximately the same level of emotional maturity. Another concept is that of the nuclear family emotional process. The nuclear family consists of the mother, father, and children. Bowen stated that there is a fixed amount of immaturity in any nuclear family that must be dealt with in some way. A typical characteristic of a nuclear family is that problems tend to come to rest more in one person than another. According to Bowen, there are 4 relationship patterns common to families: marital or partner conflict, dysfunction of one spouse or partner, impairment of one or more of the children, emotional distance from one another. Bowen discussed the core relationship between two people, such as the man and the woman, stating that one always gives way to the other. They achieve a state of equilibrium if each invests equal psychic energy in each other, but problems arise if one cannot fulfill this. For example, if some of the woman's psychic energy is directed to a child, causing instability in the relationship, the man may begin to feel unloved and cut himself off. People tend to marry spouses or partner with someone whose family of origin had a similar dynamic as their own, and then they often duplicate that system when building their own family. But immaturities that they bring with them must be dealt with, usually in one of 3 ways. First, they keep their distance from each other so they can function, often fighting and making up. Second, one experiences physical, emotional, or social dysfunction, such as drinking, trouble with the police, loss of job, or physical ailments such as asthma or arthritis. Or, third, the problems are projected onto a child and into the next generation. The family projection process is the next major concept. Projection typically occurs in all families to some extent. The child takes on some of the tension and stress, providing some relief to the parents, so parents are often not motivated to solve the problems between each other. In most cases, projection involves only 1 or 2 children, while other children remain unscathed. So children in a dysfunctional family may have very different experiences. First children are often the target, but projection can also be aimed at the youngest or at a disabled child. Most often, the mother projects onto the child because their relationship tends to be the closest, although it can occur with the father as well. The more the child is impacted by projection, the more the child's life is likely to become disorganized. Another concept is the multi-generational transmission process. Problems can move down from a distant part of the system, such as from the parents' families of origin, and become evident in an individual in the nuclear family. The child who is the victim of marked projection typically is further down the scale of differentiation than the parents and has more impairment, resulting in regression that is passed on to the next generation because, remember, people tend to marry those who have the same level of differentiation and repeat the patterns that they experienced. For this reason, some families tend to flourish over time and move up the scale, and others tend to increasingly regress and move down the scale. Another important concept is that of sibling position. Bowen stated that a large amount of one's personality is determined by sibling position in the family. For example, the oldest children are often likely to be the most responsible and to acquire the expectations of the parents toward their gender roles. These children are often highly motivated and become leaders. Middle children often receive less attention, and this can make them insecure but also more independent. The youngest may have the least expectation and remain the baby in a sense. However, if an oldest child receives projection, this child may take on the characteristics of a younger child because the projection impairs the child's development. In some cases, people choose emotional cutoff, which means they distance themselves from others in the family system in order to reduce stress as a solution to problems, such as unresolved attachment issues. Sometimes people achieve emotional cutoff by moving away or simply visiting less often because visits can cause emotional stress as old interactions resurface. However, emotional cutoff is not always a solution as the stress from emotional cutoff is sometimes intense. The concept of the societal emotional process extends the nuclear family emotional process to that of society, showing that society goes through periods of regression during which it is more unstable. This instability may be influenced by many different factors, such as environmental changes, economic health, and overpopulation. As differentiation erodes, society focuses more on feelings and less on rationality, resulting in chaos. When applying the family systems theory to therapy, the therapist focuses less on the individual and more on the relationships that have shaped the individual. As part of therapy, Bowen advised creating extensive family genograms by interviewing an individual's family members to develop a comprehensive family history going back for at least 3 generations in order to understand family dynamics. All family members are encouraged to share thoughts and feelings related to their roles in the family. The family then works together to find solutions to their problems and to learn how to provide support to each other.
In this video, we will cover what HIPAA is, the purpose it serves, what it requires, and to whom it applies to. As a reminder, this video is for educational purposes only and does not constitute comprehensive training or legal advice. HIPAA is an acronym that stands for Health Insurance Portability and Accountability Act. HIPAA is a U.S. federal law that encompasses several aspects of healthcare related to streamlining the communication of health information while respecting patient privacy. HIPAA has 5 sections called titles that each regulate different aspects of healthcare. Sections within titles are called rules. 2 of the rules with the greatest impact on nursing practice are the Privacy Rule and the Security Rule. The HIPAA Privacy Rule was designed to protect the health information of patients. Because health information is often sensitive, an individual may not want details to be publicly shared. This part of HIPAA describes the types of information that are protected, whom this rule applies to, and how this information can be used. Protected health information, or PHI, is any and all individually identifiable health information or details about a person that can be traced back to that person. PHI includes common patient identifiers, such as name and date of birth, and a broad range of other information, including demographic data and details about a patient's condition and care. All covered entities or anyone involved in the transmission of PHI within the healthcare system must follow HIPAA. This includes individual people who work in healthcare settings, as well as broader organizations like hospitals or health insurance companies. PHI can be disclosed among healthcare professionals when it is necessary to provide care. Communications, such as nursing shift handoffs or nursing reports, are necessary to provide continuity of care for patients, and are therefore reasonable and allowed. PHI must also be shared if required by law, such as a court order or a report to the federal government. Patients may purposefully disclose their own PHI to anyone and can authorize in writing the sharing of their PHI with others. Patients are also entitled to access information within their medical records by submitting a formal request. The HIPAA security rule focuses on Electronic Protected Health Information, or ePHI. ePHI is protected health information that exists digitally, like the electronic medical record. This part of HIPAA sets specific standards for keeping electronic data safe as the use of technology in healthcare increases. Under the HIPAA security rule, healthcare organizations are responsible for taking measures to protect patient information, such as encrypting data and requiring logins and usernames and passwords to access ePHI. All healthcare employees with authorized access to ePHI are responsible for guarding their login credentials, as misuse could lead to unauthorized access. A breach occurs when PHI is used or shared improperly, in a way that violates its security or privacy. Breaches vary widely in size and characteristics, but they all involve unauthorized access to or sharing of information. Any suspected or potential breach, such as a missing laptop containing PHI, should be reported immediately to the appropriate supervisor, who can then determine further action. A HIPAA violation occurs when any part of HIPAA is broken, regardless of whether an actual breach occurs. HIPAA violations may be actions or instances of neglect and can occur at an organizational or individual level. Potential HIPAA violations or breaches are serious, and even unintentional sharing of PHI must be avoided. Violations can have significant consequences, including employer-imposed sanctions and criminal or civil penalties. It's important to remember that respecting patient privacy and confidentiality is an essential part of ethical nursing practice. Laws such as HIPAA are in place to protect patients' rights, and compliance helps make sharing PHI safer and more efficient. Let's go over a few scenarios to put this knowledge into action. You are caring for an 86-year-old man who has been admitted for pneumonia. He is mentally alert and oriented and has signed a document to disclose his PHI to his wife. You receive a call from his wife during your shift asking for a status update. It is most appropriate for you to A. Verify her identity and the patient's identity before providing information. B. State, "I don't have a patient by that name today." C. Notify her that although you are caring for the patient, you cannot provide an update over the phone. Or D. Forward her call to the nurse's station so the unit assistant can answer her question. The correct answer is A. A signed document indicates that it is appropriate to share a status update with the patient's wife, and you should ensure you are releasing the information to the correct person. Which of the following is a potential HIPAA violation? Select all that apply. A. The nurse leaves a computer workstation logged into an electronic medical record when going to answer a patient's call light. B. The nurse takes paper report sheets home at the end of the shift. C. The nurse tells a story at a party about a patient but doesn't use the patient's name. D. During their lunch break in the hospital cafeteria, two nurses talk about their assigned patients for the shift. And E. The nurse asks the pharmacist about a well-known patient on a different nursing unit. The correct answers are A, B, C, D, and E. They are all potential HIPAA violations. Which of the following would be appropriate for a nurse to post on social media? Select all that apply. A. A selfie with a patient in the background being discharged after an extended hospital stay. B. A status that states, "I had a long day at work today." C. A short story about an inspirational patient that omits the patient's name. D. A photo of a patient's wound that does not show the patient's face. Or E. A stock photo of a dog wearing a scrub top and a stethoscope. The correct answers are B and E. The other answers include PHI and are potential HIPAA violations. Thanks for watching and happy studying.